All right, so this is my presentation about answering all the great questions everyone asked about my case study of SSCD. I thank you all for the questions. They really were thought-provoking. All right, so the first question is, was there anything you found either in the case history or during testing that made you think that SSCD instead of the previously diagnosed Meniere's disease, other than the no nystagmus or in the positions and an absent ECOG? Well, in my yes, the answer to the question is yes. We do a thorough case history. The patient has to fill out like 5 pages of questionnaire, like questions about the dizziness, and reading through the case history, everything about it didn't point to Meniere's disease. Also, one of the main things about Meniere's is Meniere's is episodic vertigo, so it's going to come and go. It comes in episodes that last for classic Meniere's lasts for about hour or minutes to hours. The patient here, she was having constant dizziness. She was not having any breaks in the dizziness for the last, I think, however many months she said. So that was like one of the biggest factors that pointed to something else rather than the Meniere's disease. So this one was talking about if we completed the VEMS. So if like the patient did come back for more testing, what would our protocol be doing when we did VEMS? Because I did note that if the patient did come back, VEMS would be completed. So our protocol for that would be to complete a CVEMP. And what the parameters are is that we would be using a 90 dB NHL tone burst, completing 200 sweeps per tracing, and repeating and getting 2 reliable waves. And then we would compare the 2 waves, or we would complete the right side to the left side and look at the difference from there. And I think our clinical norms were 33%. So if it's bigger than 30, if the 2 waves are 33% bigger or smaller on the affected side, then we would have a positive SSCD. Those are our clinic norms. They might be different in other places. I'm just not quite sure exactly what other normative data is, but for our clinic, it would be 33%. The question is, what is the gold standard for diagnosing SSCD? The gold standard would be a CT scan. The CT scan is going to be able to show us the third window in the superior canal. That since the MRI is looking for soft tissue, the CT scan is looking for the bone, and that CT will be able to show if the third window is there or not, and possibly how big that third window would be. So this question is, I think there's a couple questions in here. So what is the specific loud noises that trigger symptoms? I also mentioned that heat was a trigger. What's the sources? And can it just be hot outside, or does it happen when she uses a hairdryer? The patient reported loud sounds. Any loud sound causes dizziness. So loud beeps, the hairdryer, any sound that was amplified, the patient would experience dizziness. Any type of loud noise would cause it to be excessively dizzy. And the heat source is the outside heat. So during this time, it was a little bit more around ending the summertime, and we were in August, September-ish, where it's still warm here. And the heat does trigger it. It makes it worse. And she noted that she tends to not try not to go outside as much because any type of heat source. I think she did say she stopped using the hairdryer because of the loud noises and even the heat causing it to be a trigger. That's a really good question. I really enjoyed that one. Made me kind of think and had to go back and remember what she said in her case history, but she did stop using the hairdryer, which was unfortunate because her career was a cosmetologist. During tympanometry. So although the patient has not had SSCD and the audio was completed, were there any dizziness during temps? while testing tympanometry, the patient did not express dizziness. I did probe on that one too. I don't think the patient was experiencing the dizziness because she was already in the dizziness episode. I don't think the temp made it bad enough where it was going to make it worse. I also have a feeling that the temp didn't trigger the dizziness because of how big the lesion of the third window is. Sometimes a small lesion can cause such a huge a big amount of symptoms, but it wouldn't be enough to trigger it with a temp. So the temp was very interesting to see that it wasn't the classic temp that caused the dizziness. And why do you think the temp might trigger the dizziness? It's because when we are changing the pressure inside the middle ear, with that third window being open, it would be changing the pressure. It would be also changing the pressure because we have that third window causing the paralymph to move, which would result into dizziness. It looks like the neuro ABR was done at 80 dB. Was there any concerns that high intensity would cause dizziness? Yes, but overall, the patient had no hearing loss, and our clinic protocol is to perform an ABR at 80 dB NHL. But due to the fact that we did not perform acoustic reflexes because we knew the loud noises was going to trigger the dizziness to be worse, we also did not want to put a higher intensity for the neuro ABR, the clicks. Also, we did it at 80 so that we could get the repeatable and reliable waveforms, because I think she would appreciate it even if we did it under 80 dB, but this is our clinic norm, and I think going less, we probably wouldn't have gotten the waves that we did. So we tried to elicit them to where we knew they were going to be repeatable, and even during, it's noted, and I think I noted this in the case history also, is that she did have facial twitching while we were doing the testing, so I don't think upping the intensity would have been any better for her, and I don't think it would have helped the situation. I think we would have had worse waves because of so much artifact with everything happening. So the patient did have a family history of Huntington's disease. So the question is, Huntington's is genetically linked condition. It sounds like so far she does have it, which I assume to mean she does not have symptoms of it. Has she been genetically tested for it? Since Huntington's disease is progressive and eventually impacts motor function, among other things, how do you think a positive diagnosis of this condition might influence the treatment planning? Would you recommend genetic testing? So the patient did report she had been tested for Huntington's disease, and she currently does not have the disease. They've been doing genetic testings because that was one of the things that her primary care very much honed in on. Right now she does not have the Huntington's disease, but with further testing and everything, I would recommend that she still keep getting genetically tested for it, because in the research I was doing, Huntington's disease does not appear until the ages of 30 and 50 years of 30 to 50 years, and she was right under that. She is only about 32 years old. So I would keep getting the testing because it can show up at any of that time. I think if she did have a positive diagnosis, I do think this would be very beneficial in getting the correct treatment she needs. I do think we would be able to point her in the correct way of getting other professionals to help, along as in getting vestibular therapy done with a physical therapist, along with maybe getting an occupational therapist in on and then just everything, and getting all the specialists that possibly are going to be needed for Huntington's, so she has the best outcome for it. Because if this is Huntington's disease and they just haven't found it yet, since it can be progressive, I think it's better to get this all done earlier and get her paraprofessional team together faster. I think it's going to benefit her more in the end. So yes, I would recommend genetic testing, and I would recommend her to keep getting genetic tested until at least 50 years old, so that we can keep up and see if she does have it or not. And that is all the questions. I want to thank you guys for answering them, or asking me questions, and they were really good and definitely made me think. I hope everyone's doing well, and I hope to hear good things. All right. Bye.